Working here? All right. Good afternoon, everybody. Welcome to the 31st Annual Jim Steele Memorial Lecture. Before we get started, just some housekeeping information before we get going. This lecture, in addition to in person, is a webinar that is being recorded. So when we get to the Q&A part, if you don't want your voice captured, then you can, in Houston, you can shout out your question off mic and I can repeat it. And if you're online, you can just enter your questions in the chat and I will ask those at the end. Before we start, I'm going to introduce Dr. Hebert DuPont, who helped to establish this lecture series in memory of Jim. Of course, Jim was around for many years while his lecture was ongoing. And so Bert is going to give the history of the Steele lecture, and then I will introduce our speaker for today, Dr. Peter Hotez.
Well, it's a great day to celebrate the life and legacy of Jim Steele, who Palmer Beasley, who was a former dean here, and I established this lecture. And we got to know Jim because both Palmer and I were at the CDC as Epidemic Intelligence Service officers at the beginning of our careers in infectious diseases. And Jim Steele was a force at the CDC like none other. He sat in the back of the room at the EIS conference, as he did during 20 of the annual lectures in his name here. He would sit in the back of the room, and his voice would boom forward, and you felt that this was a message from heaven coming towards you with some great importance. And certainly the things Jim said were important. He's the father of veterinary public health, a giant in public health and veterinary medicine, literally and figuratively. He was as tall as I was, but weighed 100 pounds more than I weigh. In his early years, he and Joe Mountain established the CDC in Atlanta. He was one of the few people that were involved in the establishment of the CDC. During his years as Assistant Surgeon General for Veterinary Affairs for the U.S. government, he worked with a number of different administrations, and as we say in the slide here, he's trained essentially all the leaders of veterinary public health, or he's trained the people who have trained those people. He established really the term of zoonoses, which is disorders, infections that are transmitted from humans from animals. And we now know that a majority of emerging infectious diseases are zoonotic disorders, and all of the pandemic infections in the last 120 or 30 years have been zoonotic infections. Here's my last slide. There's two pictures of Jim. The one that you see on the left is the second James Steele lecture, and in the middle is Roger Glass, who gave that lecture. Dr. Glass is the head of the Fogarty Institute at NIH, and Palmer Beasley is at the far left. The picture at the right is Palmer at the far right, I'm at the far left, and Jim is in the middle. We're propping him up. This is in 2004. This is the 11th lecture that was established in his honor. Palmer and I decided to recognize Jim Steele on his 80th birthday. And if you can imagine starting a lecture of a very important luminary when they're 80 and having them actually watch 21 of those annual lectures, you get an idea of how long Jim was with us. He made an impact in safety of food in this country. He trained all the veterinary public health people, and he put zoonoses on the map. And I know Jim would be very happy with our speaker today. But I will end that comment by just saying it's a great day at the School of Public Health when we get to honor such a luminary as Jim Steele.
Thank you, Dr. DuPont. So it's my privilege to introduce our friend, colleague, and neighbor, Peter Hotez, to speak with us today. Dr. Hotez received his undergraduate from Yale in biophysics, molecular biophysics. He received his PhD in biochemistry from Rockefeller University, and he followed that up with his medical degree from the Weill Cornell Medical College. He has co-authored over 600 papers and published five books. He is currently the Dean of the National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at the Baylor College of Medicine. He is also co-director of the Texas Children's Center for Vaccine Development and the Texas Children's Hospital Endowed Chair of Tropical Pediatrics. And in his role as director, co-director for the Center for Vaccine Development, he has overseen the development of vaccines for hookworm disease, for schistosomiasis, leishmaniasis, Chagas disease, SARS, MERS, and of course, SARS-CoV-2. So without any further ado, I'd like you to welcome Dr. Peter Hotez.
I'm going to try to stand in front of you today because I've noticed someone of my stature, when you stand behind podium, all you see is podium. So it's a little better, and I really appreciated, Dr. DuPont, your remarks, and you've been a wonderful colleague and friend over the years that I've been here, and same with you, Dr. Barwinkle, in the School of Public Health, and Eric, and I deeply appreciate your collegiality. One of the reasons I came to the Texas Medical Center was not because of any one particular institution. I was just impressed with the depth and breadth of the whole medical center, and so I've always treated this school with the same kind of collegiality as being at Baylor or Texas Children's Hospital, and that has paid off in multiple ways. We've had multiple University of Texas graduate students, MPH students in our labs over the years for doctoral dissertations. And Christy Murray's been a big help in sort of helping to foster those links, and it's been one of the real pleasant aspects of being here at the Texas Medical Center. I also appreciated the comments about Dr. Steele. I'd first met him when I came to the TMC in 2010, and so I had the pleasure of having him around for a couple of years. And you're absolutely right. His voice still had some booming qualities, even then, and it was a real pleasure to get to work with him and seek his advice. Because if you remember, that turned out to be very important, as about a year or so after he passed, then we had Ebola and a series of other zoonotic infections like COVID-19, and so his legacy is more important than ever, because some of our worst pandemic threats are ultimately derived from animal sources, whether it's bats or livestock or other intermediate animal hosts. So he was definitely ahead of his time, and so it's an honor for me to be able to talk to you and give you a lecture in his name. I'm going to begin here. This is kind of a yin and yang talk, in the sense that I'm going to talk about both the positive aspects of vaccines and our work on vaccine development, but I also have to talk about the negative in terms of what's happening with a rising and aggressive anti-vaccine movement. So, one part I planned for, the other part I didn't. So my dream was to be an MD PhD scientist. I did that in New York at Rockefeller University. On the left-hand side, where the motto of the university translated science for the benefit of humanity, or knowledge for the benefit of humanity. And that's why I started making vaccines, because I saw vaccines as one of the highest expressions of science for the benefit of humankind. The part that I didn't quite anticipate was of our 4 adult kids, that Ann and I have, Rachel, and we live in the Montrose area, and you might see Rachel going around walking to Goodwill in the morning. She has this big shock of red hair, and she has autism and intellectual disabilities. And I wrote a book called Vaccines Did Not Cause Rachel's Autism, because that was the OG assertion from the anti-vaccine groups, that vaccines cause autism, and I explained why they didn't. I'll talk a little bit more about that in a minute. But that wound up making me public enemy number 1 or 2 with the anti-vaccine groups. And that had the advantage of not only becoming an expert in vaccine science, but also the anti-science, because it kind of gave me a front row seat. And today I'll talk about how what started out as phony baloney around vaccines causing autism to becoming this political empire. The other thing that happened on the bottom there, these are the books I've written since coming to Houston. You don't ordinarily think of moving to Houston to become a writer, right? But I think part of it was being in New Haven and New York and Washington, D.C., where everybody was a writer. I felt intimidated. There was something liberating about coming here to Houston, and I've been writing books, and that's become a new source of great fulfillment. So I'm going to start here. So after I did my MD and PhD in New York, I became a pediatric house officer in Boston at the Mass General Hospital. And back then, they actually had microscopes in the emergency room. And Dr. DuPont, you'll know this better than anyone, it was the house officer's job to, after you did the lumbar puncture, you did the gram stain of the cerebral spinal fluid, and you made the provisional diagnosis. Ultimately, it was sent to the bacteriology lab, but you made the provisional diagnosis. And your heart sank when you saw these gram-negative organisms and polymorphonuclear leukocytes, because you knew there was a high likelihood this child had bacterial meningitis. And particularly then, one of the most common causes was Hib, Haemophilus influenza type B meningitis, and the high likelihood this child was going to have permanent neurologic deficits, deafness, and may not even survive. And that took a big toll not only on the families, but also the house staff. And I was admitting a child every few weeks with this devastating condition. And then while I was a house officer, there were a series of improvements in the vaccine. So the original vaccine was the polyribophosphate capsule of the bacterium. And then John Robinson and Raquel Schneerson at the NIH figured out how to conjugate that to protein, which haptenized it and made it work as a vaccine in young infants. And that development happened while I was a house officer, and it got quickly adopted, so that this is what happened to the incidence of Haemophilus influenza type B meningitis, Hib meningitis. In the few years I transitioned from a house officer to being a junior attending in pediatric infectious disease. It basically went from a devastating condition every few weeks I was admitting a child to one I would talk about purely for historical interest. I would talk to the subsequent generation of house staff like they would talk to me about diphtheria or tetanus, and it was that dramatic. And that said to me, if you really want to make impact, vaccine development is certainly one way to do that. And the world more or less agreed. And what happened in the year 2000 was the global leaders got together at United Nations headquarters to draft these Millennium Development Goals, mostly around poverty reduction, recognizing there was 1 billion people in the world that live on less than $1 a day at the time. They called them the bottom billion. And what was forward thinking about that was tying health to poverty reduction. So three of the 8 Millennium Development Goals for health, for poverty reduction, were actually tied to health, including number 4, represented by that little teddy bear there, to reduce child mortality. That's what stimulated the formation of what became known as the GAVI Alliance. Back then it was called the Global Alliance for Vaccines and Immunization. Now we just refer to it by the acronym GAVI. And this is also when the Gates Foundation started. And the first big tranche of money from the Gates Foundation was $750 million back in 2004, the GAVI Alliance. And the alliance is a partnership between the international agencies, the World Health Organization, the UNICEF, the World Bank, also the pharma companies, also academic partnerships, and the Gates Foundation, with the idea that we're really going to drive childhood immunizations to the point where we can talk about eliminating disease. And we have some metrics now to know that turned out was very effective. And these are metrics that were derived by another organization that was set up by then, the Institute for Health Metrics and Evaluation at the University of Washington, Seattle, headed by Chris Murray. You might have seen Chris Murray and Ali Mogdad a lot on CNN during the pandemic talking about COVID, but they were really set up to monitor the progress of these big picture global health programs. The last enumeration I have is for 2019. The 2021 numbers will probably come out pretty soon. But you can see the dramatic impact, from in 2000 when the GAVI Alliance was started, 500,000 kids were dying every year of measles, now brought down under 100,000 deaths. So an 87% reduction. Or similar story for whooping cough, pertussis, tetanus, diphtheria, Hib meningitis, really dramatic impact. Still a lot of kids dying, but a fraction of what was dying before. So this was a resounding success. Those black and white pictures on the right are from the Brazilian photographer Sebastião Salgado, who in a moment of exuberance went around the world photographing kids getting their vaccinations, mostly the polio vaccines. I first saw them in an exhibit at the Pan American Health Organization, but now you can download a lot of those images on Google, and I like them mostly because of the expression on their parents' face, everything from hope to joy to fear to bewilderment. It's a very moving set of images. And that's where we've been up until about 6-7 years ago, when there's been a fraying, or I don't want to say unraveling because it really hasn't unraveled, but there's been some pause for concern because of geopolitical events that are starting to dissolve components of that vaccine infrastructure. And I wrote about this in my last book called Preventing the Next Pandemic. And what it does is it looks at some of the big picture drivers that are bringing back vaccine preventable diseases and neglected diseases. And there are things like poverty and war and political instability, and urbanization and deforestation and human and animal migrations, climate change, anti-science, and a lot of these things James Steele was out in front and talking about. And they're bringing back disease in unique and interesting ways. So the book looks at several case studies of where this is happening, because it wasn't happening homogeneously across the world. They were initially in some regional areas, although now it's starting to coalesce and expand. So an example was on the Arabian Peninsula, in the Middle East, in North Africa. And I saw this firsthand. I served as U.S. science envoy in the Obama administration for the Middle East and North Africa. And what was happening there was in Syria and Iraq, in the ISIS-occupied areas, there was a slowdown or an actual halting of childhood vaccination programs. And the first one that comes back, of course, is measles, because measles is the most highly transmissible. So the more transmissible an agent, the higher the vaccination rate needs to be in order to keep the pathogen in check. And so measles was the first one coming back, but we're also seeing the return of polio. And it was not only vaccine preventable diseases, so there was a slowing and stoppage of vector control programs like sandflies for leishmaniasis. So this is not a fatal disease. There's a child with it on the right, but it can be highly disfiguring, which was especially stigmatizing for girls and women. So 1,000-fold rise in cutaneous leishmaniasis transmitted by sandfly that injects the leishmania parasite. Or in the lower left in Yemen with the civil conflict and the war by proxy between Iran and Saudi Arabia, created one of the world's largest cholera epidemics. But that's not the only thing that's going on. You had unprecedented temperatures of 50 degrees Celsius on the Arabian Peninsula due to climate change. And this was drying up ancient agricultural lands along the Tigris and Euphrates, causing people to flee into cities like Aleppo and Damascus, which is then outstripping urban infrastructure for sewage, bringing back diarrheal disease, or the crowding causing respiratory infection. So the book kind of looks at how all of these, now we start talking about climate change, but the book looks at how all of these social determinants and climate change interact in unique and interesting ways. And closer to home, we're seeing something similar in Central Latin America, particularly in Venezuela, with the socioeconomic collapse of the Maduro regime people desperate for employment working in the illegal gold mining industry, and then sleeping outdoors without bed nets and being exposed to malaria mosquitoes, so more than 1,000-fold rise in malaria, even though Venezuela was at the forefront of malaria control. And then same deal with the vaccines, halting vaccination programs, and the first one to come back is measles. And then as people fled the country going across the border from Venezuela into the Brazilian rainforest, coming into contact with ancient indigenous people and causing decimating measles epidemics among the Yanomami and other indigenous people, or across the border into Colombia, coming into contact with the Wayu, and then prolonged drought from climate change. So again, how this interacts in unique and interesting ways. And guess what? So Texas and the Gulf Coast is on this list. When you talk to the climate change people, they'll tell you that Texas and the Gulf Coast has a special vulnerability because of sharp increases in temperature and catastrophic weather events, also human migration. So some of those same forces are operating right where we are. So on the lower left is some predictive maps from Simon Hayes' group at the University of Washington, the Institute for Health Metrics, looking at the return of arbovirus infections. So the prediction is if we continue on the same course, dengue is going to become a regular feature here on the Gulf Coast, as is Zika and chikungunya and other arbovirus infections. But we're seeing Chagas disease and murine typhus. Our group, Rogelio Mejia, got approached by an environmental justice activist, Catherine Coleman Flowers, who talked to us about the raw sewage in poor areas in southern Alabama. And we went and sure enough found hookworm infection is still highly prevalent there. People thought this was long eradicated, but it wasn't. So, the Texas and the Gulf Coast is also a significant region now for illness. And one of the reasons why we set up our school and research unit around tropical diseases is I like to tell my friends and colleagues at the London and Liverpool School of Tropical Medicine, the difference is we're in a disease endemic country, the Republic of Texas, and with it comes a lot of responsibilities. And that's been a hard message to get across because people don't want to talk about poverty-related diseases in high-income countries. But one of the findings that I made in one of my books, The Blue Marble Health, said there's a surprising burden of illness due to tropical infections in countries like the United States and other G20 countries, but it's the poor living among the wealthy. And that's a tough message to get across because when you talk about this in Washington, D.C., the first thing people want to say is, well, we just got to build the wall higher, right? Because they want to blame migration across the southern border, when in fact we can show there's transmission here. 10% of the dogs are infected with Chagas disease, right? The dogs are not slipping in across the border from El Salvador. We have transmission here in the state of Texas. And that's been very tough to get people to be concerned about. Finally, Cory Booker, a senator from New Jersey, has gotten very interested in this and has now submitted legislation called the STOP Act, the Study, Treat, Observe, and Prevent Neglected Disease and Poverty Act, where we actually start doing the active surveillance, going into poor communities where we suspect these diseases might be, because they're often off the beaten track. People don't often recognize it, so somebody with Chagas disease would see their cardiologist, if they ever get access to a cardiologist, and then the cardiologist was not even aware that Chagas disease transmission was occurring, so it would get misdiagnosed. So we're trying to do more of that. And then our big research activity, of course, is trying to develop vaccines, and that's the only thing that needs to be done, but our contribution and my personal contribution is trying to develop the vaccines that oftentimes the pharma companies won't make. It's not to demonize the pharma companies, they do a lot of important things, but what do you do for vaccines for diseases such as schistosomiasis and hookworm and Chagas disease and leishmaniasis, where you can't hope to ever achieve any kind of meaningful rate of financial return because these are diseases affecting the poorest of the poor. So together with my science partner, Dr. Mary Elena Patazzi, we set up this very interesting center for vaccine development, which is based mostly in the Feigen Center of Texas Children's Hospital right across the street, and you're all invited to come and visit us. It's kind of a hybrid culture between a biotech and an academic enterprise that's actually making a vaccine. And it's funny, the reason we started making coronavirus vaccines more than 12 years ago was we saw SARS and MERS, and we said it's probably just a matter of time before there's another coronavirus pandemic. And the problem is vaccines for SARS and MERS were orphaned as well. SARS, of severe acute respiratory syndrome that arose out of China in 2002, and Middle Eastern respiratory syndrome, MERS, in 2012. And that's why we started developing coronavirus vaccines. It was the same mindset, vaccines for global health that were orphaned by the pharma companies. So when the COVID-19 sequence hit, we were able to flip that around and make that vaccine as well. And our approach is we try to do cool and innovative things like mRNA and adenovirus vector vaccines. But the other thing that we do is we try to be compatible with vaccine producers in low and middle income countries that actually band themselves together in a network. They call themselves the Developing Country Vaccine Manufacturers Network, DCVMN. There's about 40 of them in Asia, Africa, and Latin America. And one of the most common technologies that they have is many of them make their own recombinant protein hepatitis B vaccine. So this is done through microbial fermentation in yeast, growing up yeast in a bioreactor, almost like the process for making beer, except these are genetically engineered yeast, whether it's Saccharomyces or Pichia, that's actually secreting the antigen. So it has a lot of advantages. It's low cost. It typically produces stable proteins. You can scale it fairly easy. So the thinking is if you had countries like Bangladesh and China and India and Indonesia and Thailand, Vietnam, Argentina, Brazil, and Cuba, all making their own recombinant protein hepatitis B vaccines, if you want to make vaccines for global health, the model was we'll create the prototype here in Houston, here in the Feigen Center, then we'll transfer the technology, minimizing strings attached so they can do the scale up and production. And so we began by diseases like this for hookworm and schistosomiasis, two parasitic worm infections that the pharma companies would never consider making for those vaccines. And I show this picture because of the map. Imagine if you're the CEO of a biotech company. This is probably not the map you want in your business plan, right? Because the financial return is all about North America, Western Europe, and Japan. Yet these are diseases that almost exclusively are found on the African continent, the poorest areas of Latin America and Brazil and Southeast Asia. So how are you going to make those vaccines? And the one for schistosomiasis has really reached crisis proportions, especially among girls and women on the African continent. The spine-shaped eggs that we learned as students got into the bladder and the liver are also, now we realize, getting into the female genital tract because nobody was doing colposcopic exams on girls and women with this condition. And now we realize almost half of them, 40 million girls and women, have those lesions caused by the spine-shaped eggs in their cervix, uterus, lower genital tract. It's a cause of pain and bleeding, social stigma, depression, marital discord. It often peaks in the teenage years, and adolescent girls get falsely accused by community health workers of being sexually promiscuous, when in fact they're getting it by standing in water contaminated with the larval stages of this parasite. It's also associated with the 2 to 3-fold risk in acquiring HIV/AIDS, probably because of the ulcerative lesions in the cervix, uterus, and lower genital tract. Who makes that vaccine? So we're doing this now, and it's in phase 2 clinical trials. It's based on a surface protein, which is a good target for the immune system. It's a recombinant protein vaccine known as tetraspanin 2. And now we've finished phase 1 clinical testing in the United States, and we did this with a vaccine trial evaluation unit, which happened to be based at Baylor, so Wendy Keitel and Rob Atmar, and these are some of the phase 1 trial results, so we're getting good immunogenicity. But the reason I'm showing you this slide is to call your attention to this GLA-AF. That stands for glucoperanylyl lipid A. It's an adjuvant, so we're desperate for access to adjuvants, which the pharma companies fiercely hang on to. And that's always a challenge that we face making vaccines in the nonprofit sector. Anybody here get their Shingrix vaccine? How'd you like it? It hurt, right? Yeah, it hurt like hell. And the reason it hurt like hell for many of us is because it's a recombinant protein formulated with the GSK adjuvant AS01, which is loaded with TLR agonists, toll-like receptor agonists. We don't have access to that. So we have to try to sort of find ones that will mimic it. So this is an open access glucoprenosyl lipid A, a TLR4 agonist from what used to be called IDRI, now they're called AHI. It's a nonprofit. So that's always a constant struggle. Our Chagas disease program is, this is a little bit different. This is a therapeutic vaccine. So Catherine Jones and our group heads a lot of our Chagas disease activities. The problem that you get into with Chagas disease is the benznidazole antiparasitic chemotherapy works really well in the acute stages and early chronic stages, but as the disease progresses and heart disease begins, so the early stages of cardiomyopathy, the drug does not work very well in terms of eradicating the parasite, the Trypanosoma cruzi, from the heart, and the ensuing sequence of events leading to fibrosis, leading to inflammation. So they need something else. So this is a therapeutic vaccine that we're developing in collaboration with a group of institutions in Mexico, the Autonomous University of Yucatan, the Sinvastav, the Institute for Advanced Studies, and this is supported by the Carlos Slim Foundation. And we're actually manufacturing in Mexico at an organization called ProBiomed. So this will go into phase 1 clinical trials, and a very interesting clinical trial design of trying to look and see how this vaccine slows or halts the progression of heart disease in those people who are already infected. And then we come upon this, and so this was what the unvaccinated world for COVID looked like in 2021, and with the African continent almost completely unvaccinated, same with India, Pakistan, South Asia, Southeast Asia. And we were getting desperate phone calls from ministers of health and ministers of science for what was really a science policy failure. And the science policy failure out of Operation Warp Speed and from the G7 policymakers was this overwhelming emphasis on speed and innovation and cool new technologies like mRNA and particle and adenovirus vectored vaccines. And no question, we advanced that whole world, that whole ecosystem of vaccine technologies. Do we have any engineers here? Anybody with engineering training? Yeah, come on. Well, any engineer will tell you, when you focus on only brand new technologies, there's a learning curve before you go from 0 to 14 billion of something. I don't care what it is, widgets or anything else. It takes time to learn how to scale from 0 to 14 billion. And that was the problem. There wasn't that situational awareness to say, hey, maybe in parallel, we should also have some technologies that we can plug and play right with the developing country vaccine producers. And so that's where we came in. We filled that niche we could hit the ground running working with vaccine producers locally because unfortunately enough vaccine was made, enough mRNA, adenovirus, and particle vaccines were made to vaccinate the high-income countries, basically, North American countries and Europe, and that left the LMICs, the low and middle-income countries, out in the cold. And that's what led us to develop this technology, which we transferred with no patents. We minimized strings attached to several countries, including India, Bangladesh, that had vaccine production capacity, Botswana, and Indonesia. And India went the furthest with a vaccine producer known as Biological E. They're like the Serum Institute of India, which is a little better known. And they wound up making several 100 million doses of our vaccine technology, which they named Core BVAX, the BE for Biological E. And this is now 75 million doses have gone into kids, and another 10 million as for their primary immunization, another 10 million for their adult booster. So, we provided proof of concept that you don't have to be a big pharma company to still do big things. And you have to be in Texas to do big things still, but you don't have to be a big pharma company. And I think that's very important. It's not to demonize the pharma companies. They're going to do what they do. But the idea is to create alternatives in the model, alternatives in the ecosystem of academic partnerships with local vaccine producers. And it's an interesting story. So this is a PowerPoint slide you might see in one of our lab meetings. You know, over the years for the SARS and MERS receptor binding domain, which is what this recombinant protein is, we had tweaked the molecule in the following way. So that little red bar on the upper left is an N-terminal asparagine. It's a glycosylated amino acid. We figured out that you have to engineer it without the N-terminal asparagine because its glycosylated was interfering with the immune response to the protein. Or in the green bar there's a free cysteine that was causing intermolecular disulfide bonds that were interfering with production because it was causing aggregation. So we had to engineer that out. And that took, even though it's not amazing, it took us time to figure out. And that allowed us to hit the ground running when COVID-19 came along. And I'm showing you a picture of this paper in Biochem Biophysica Acta, not because it's the most amazing paper in the most amazing journal that you'd ever see. I'm showing you exactly for the opposite reason, because it's not the most amazing paper in the most amazing journal, right? Making a tweak to a molecule to remove an N-terminal asparagine or changing a cysteine is not going to get you in Cell or Science or Nature, but we're a hybrid. And so our lead scientists not only are producing vaccines, but they need papers as well. So this is a kind of a way to work out that hybrid culture. So things that we've had to kind of figure out by the seat of our pants. But the other nice thing about it, it means that every step of our production is in the open access literature. So in theory, anybody could download our papers free, you know, from PubMed and absolutely reproduce what we're doing. We actually make it easier by providing the production cell bank and some of the technical know-how, but that's the idea behind it, really being very transparent in how we do this. And then we actually do the early stage production, and then with the Emory Non-Human Primate Center, we showed that the vaccine would block a virus replication, and the lungs looked almost pristine, so we knew it was a really good vaccine, and we were quite excited about it. But then what? So we were getting these desperate phone calls, so we started, what we would do is some due diligence, because you didn't want to give it to someone that never made a vaccine before. The idea behind it was because if they messed it up, that would tarnish the reputation for everybody. And then, you know, the vaccine would get voted off the island, and we didn't want that to happen. So we did some due diligence to make sure they knew what they were doing, and then we transferred our technology. And these are the countries we did it in. And practically speaking, that meant a lot. If you've ever done business with Asia or on the African continent, it's a lot of early morning Zoom calls, right? So my day was starting at 4 or 5 in the morning, and then during this period, my day was ending with Don Lemon on CNN and Lawrence O'Donnell on MSNBC. So ending at 11 o'clock at night. So I didn't sleep for 3 years, but we got some things done, and we kind of practiced our own version of Texas vaccine diplomacy. I say that because we were not part of Operation Warp Speed, because we were not a pharma company. So what do you do in terms of raising funds? And you know, this is one of the blessings of being here at the Texas Medical Center and being in Texas is private philanthropy. So the Clayburgh Foundation, you know, the King Ranch helped us, the Dunn Foundation, the MD Anderson Foundation. I'm pretty confident this would not have happened had we not been in Texas, which is one of the stories I always like to tell when going on CNN or MSNBC, because you know how they represent us, right? All they want to do is focus on all the wackadoodle going on in Austin, right? But I say, no, I came to Texas to up my game for science and innovation. And it's a story that not enough people know about. Tito's Vodka gave us $2 million. So not that I'm endorsing alcohol consumption, but should you have a vodka containing cocktail this evening? You don't want to drink the Russian stuff anyway, right? So support Tito's. And then what we do is we transfer the ownership. So we say, look, we're not going to hang on to this concept of decolonizing the vaccine ecosystem. You guys own it. So when we did that, so Biological E owned the technology at that point, and SEPTA in Bangladesh owned theirs, Biopharma in Indonesia owned theirs, and then they work out with their own national regulatory authority how to do the clinical trials, how to do the data sharing, how to work with the World Health Organization. So this is their paper on the phase 1, phase 2 trial, and the level of virus neutralizing antibodies look really good. I mean, it's up there with mRNA vaccines and more durable actually than mRNA. So I think it actually has some superior features, much better than the adenovirus vectored vaccines or the whole inactivated vaccines. And then we did the step-down studies in children, and they used this as the primary pediatric immunization. So by March last year, kids all over India were getting vaccinated, 75 million doses for the primary immunization in kids, another 10 million adult boosters. And then we worked with Indonesia, same deal. With Indonesia, they called their vaccine Indovac, a slightly different construct. And then what was very interesting is their government people actually came into our labs because we explained to them that this is a vegan technology, microbial fermentation, or it can be a vegan technology. There's no animal cells or human cells or animal proteins or human proteins. And being that sort of biotech-like organization, the source of every reagent we use is cataloged. So if we get something from Millipore Sigma or, you name it, Biorad, everything, there's the catalog number, all the information, how the ingredients were all derived, and they could confirm that it was indeed vegan. So they then worked with their clergy to get it certified as Halal. So it's one of the first Halal COVID vaccines. So very interesting things start to happen as you go to that level of scale. And so now we're making the BA4, BA5 booster version. That's going in through clinical trials. And now we're looking at a universal coronavirus vaccine technology. So that's exciting as well. So we're still continuing to innovate and revise. In the meantime, the World Health Organization is looking at what happens if and when we get on the other side of COVID. What's happened to the whole vaccine world over this time. And it's not looking so good. So the World Health Organization just put out their Immunization Agenda 2030, looking at this, and it's starting out pretty rough in part because of all of the social disruptions due to the COVID pandemic. Really put a dent into global immunization programs. So this comes from the World Health Organization. Look at the yellow lines there. The global vaccine coverage has dropped from 86% in 2019 to 81% in 2021. It may not sound like a big drop, but it's the first time it's gone the wrong way in decades. So that sets off a lot of bells and whistles and red flags. Or look at the bottom one. In 2021, the number of completely unvaccinated children has increased by 5 million since 2019. So the worry is that there's some kind of permanent tear in the matrix, in the vaccine ecosystem. So my worry is that what's happening is we're not getting back to baseline. And we're not getting back to baseline because of a new rise in U.S. and global anti-vaccine activism. So that's me in the monk painting over there. That something new and ominous has happened. And that's what I want to finish on, kind of describing for you that ecosystem. And because people don't really understand it, they call it the infodemic, or they call it misinformation. And it's none of those things. It's organized, it's deliberate, and it's politically motivated. But it's changed over time. So I want to end by quickly taking you through the brief 25-year history of the anti-vaccine movement, version 1.0, 2.0, and 3.0. Version 1.0, the OG assertion was that vaccines cause autism, and that thread is still with us today, but it's not nearly as dominant as version 2.0, this politicized movement around this banner of health freedom, medical freedom, and now we're starting to see globalized. So I want to have a very heart-to-heart discussion with you about how I see this evolving, and I'm happy to stay as long as you like for questions about it. So let's go through 1.0, 2.0, 3.0. Okay, 1.0, vaccines causing autism. That came out of a paper that was retracted by The Lancet. The paper came out in 1998, and the claim was the MMR, the measles, mumps, rubella vaccine, a live virus vaccine, had the ability to replicate in the colon and somehow that led to autism, or it was then called pervasive developmental disorder. The paper was shown not to be true, and in fact, the US government and European governments invested huge amounts of money to do large cohort studies showing kids who got the MMR vaccine were no more likely to acquire autism than kids who didn't get the MMR vaccine, and similarly, kids on the autism spectrum were no more likely to have gotten the MMR than kids not on the autism spectrum, and that pretty much killed it, which was great. But the problem was, over time, anti-vaccine groups began to monetize the internet. They were selling phony baloney autism cures, nutritional supplements, books on Amazon. And I mean, if you go to Amazon.com and type in books on vaccination, it's almost all anti-vaccine COVID conspiracy books. And so they weren't taking no for an answer. They had too much invested in this. So they would just switch up what the assertion was, or you'd play this kind of Pyrrhic game of whack-a-mole or moving the goalposts. They would come up with something else. So then it became thimerosal preservative that used to be in vaccine. Again, the scientific community would respond, but then it became, okay, that must be spacing vaccines too close together, or alum in vaccines. And it became really this exhausting exercise trying to refute all of the fake assertions. And then it even pivoted out of autism for a bit to the HPV vaccine for cervical cancer and other cancers, with the false claim that they caused infertility or autoimmunity. How many people heard that about COVID-19 vaccines, that they cause infertility? Yeah, that's where they got it from. They just copy-pasted the fake assertion from HPV onto COVID-19. And that's where I got involved. Here I said, look, I'm a vaccine scientist. I have a daughter with autism and intellectual disabilities. If I don't say something, who will? So that's me with Rachel in Cafe Brazil on Westheimer, so near where we live. And so she likes to go there on Saturday evening. And then wrote the book. And the book does kind of a deep dive showing the science that there's no link between vaccines and autism, but also what autism is, how it begins in early fetal brain development through the action of autism genes. And there's been about 100 autism genes that have been identified and sequenced, mostly by the Broad Institute at Harvard, MIT. We did whole exome genomic sequencing on Rachel and my wife Ann and I, and identified a gene that was not the same but similar to the other ones. It was a neuronal spectrin, a non-red cell spectrin. So a lot of these are neuronal cytoskeletal proteins. The point is there's an alternative narrative out there. Also the role of epigenetics. Ever try to describe epigenetics to a lay audience? That's fun, right? DNA, histone acetylation, and microRNAs. But so work still in progress. The point is there's an alternative narrative there. And that's where the aggression really revved up. On Instagram, they started calling me the OG villain, which I'm so old and square, I'd had to look up what that meant. So the original gangster villain. So your Dean Boerwinkle's invited the OG villain to come and give the James A. Steele lecture. But it had some effect, and I think it did start taking some of the wind out of the sails of the anti-vaccine movement. So they needed to regroup, and they regrouped in a way that I would not have necessarily predicted. And like so many things, it started in Southern California but amplified in Texas. So what happened was, by the 2010s in California, so many kids weren't getting vaccinated because parents had unwarranted fears about causing autism that in Orange County there was a large measles epidemic, 2014, 2015, and the California legislature responded by shutting down vaccine exemptions. They said, from now on, you want to send your kids to school, your kids have to be vaccinated. And that actually worked. It really took care of the measles problems. It drove MMR vaccination rates up. I supported it. But it also produced a backlash. And the backlash was from groups, libertarian groups, saying, hey, you can't tell us to do what we want to do with our kids. And it found a new home, unfortunately, in our state of Texas. And it got backing from the Republican Tea Party that gave it PAC money. So from Empower Texans, they formed their own anti-vaccine PAC, lobbying the legislature to make it harder and harder to vaccinate our kids. This is playing out right now in the state legislature. Some of the legislation that's being introduced is just total wackadoodle. But the consequence was we're up around 100,000 kids not getting their full complement of vaccinations in the state of Texas now. And this doesn't even incorporate any of the homeschooled kids in Texas. We have over 300,000 homeschooled kids in the state of Texas. So what percentage of those are not getting vaccinated, the homeschooled kids? 10%? 20%? 80%? Yeah, it's a trick question. We don't know. They're homeschooled, right? So we have no clue but it's probably high, right? So the point is a lot of unvaccinated kids, and that's what's come off the rails in this time of COVID-19, the pandemic. It's that health freedom, medical freedom link to the far right is what's really taken off. And it's among the hardest things I've ever had to talk about for reasons which I'll articulate. But I just wrote about this in an article called The Great Texas COVID Tragedy. And it goes something like this. So what I'm showing you on the x-axis is a timeline from 2020 to 2022. And those peaks are peaks of deaths in the state of Texas. And let me take you through it. So the virus was introduced from Southern Europe into New York around this time. Then in that first summer of 2020, we had our first big wave from the original lineage. This is the alpha wave, that devastating alpha wave. In the winter of 2021, here's the Delta wave. In the last half of 2021, here's the BA1 Omicron wave. So what's this green arrow? This green arrow points to May 1, 2021. That's when the Biden administration announced that anyone who wanted to get a COVID vaccine could get a COVID vaccine. And so vaccines were freely and widely available. And if you look at countries like Australia and Canada that have roughly a population and economy similar to Texas, after the equivalent of their green arrow, the deaths largely halted because people agreed to get vaccinated. In Texas, the deaths kept right on going. In fact, almost as many Texans died after the green arrow as before the green arrow. And so of the 94,000 deaths in Texas from COVID, so Texas, arguably the worst affected state, it's sort of neck and neck with California, but of course Texas is 28 million people, California is 40 million people. But the game changer was after the green arrow, 40,000 plus Texans died, almost half, because they refused to get a COVID vaccine, because they became victims of this anti-vaccine aggression, which I'll tell you about. Nationally, I put the number of around 200,000, mostly in conservative southern states, especially during the Delta wave and in the BA1 Omicron wave. So 200,000 lives needlessly lost. And now we're starting to understand why this happened. And it's the hardest message I've ever had to talk about, but I just haven't found a way to talk about it without talking about it. So I'm going to talk about it. So it goes something like this. If you look at it by a political map, red being Republican, blue being conservative, you can see that pretty much all of the deaths in that Delta wave were in conservative states, and the redder the county, the lower the immunization rate and the higher the death rate. And this comes out of Charles Gaba's analysis from ACA signups. The New York Times has reproduced it. The National Public Radio has reproduced it. Axios has reproduced it. Then David Leonhardt, the New York Times, just calls it red COVID. And we know why. It started with the CPAC conference in 2021 in Dallas. First they're going to vaccinate you, then they're going to take away your guns and your Bibles. And as ridiculous as that sounds to us, thousands of people in Texas, particularly in East Texas, Central Texas, up in the Panhandle, accepted it, and they paid for their lives. It was the members of the House Freedom Caucus who openly pushed false anti-vaccine statements, making false claims about the safety and effectiveness of the vaccine. Marjorie Taylor Greene from Georgia called people like me medical brown shirts, using Nazi paramilitary analogy because they compared vaccinations to the Holocaust. Senator Johnson from Wisconsin held these roundtables about vaccine injury, and then Fox News capitalized on it. And this is documented by Media Matters, the watchdog group, as well as a social science group out of ETH Zurich. which is like the MIT of Central Europe. It's the Federal University of Technology. Every night during this Delta wave, Tucker Carlson, Laura Ingraham filled their nightly broadcasts with phony baloney anti-vaccine statements and saying the vaccines weren't safe and they didn't work. And people believed it. People watching Fox News every night went down that rabbit hole. And we know the demographics that were surveyed by the Kaiser Family Foundation, in addition to having on the conservative Republican side, tend to be younger age group. So, not your traditional Jim Baker type Republicans, but a younger group, more rural than urban, and low educational attainment. That was the demographic profile. And the hardest part is how the heck do we talk about this, right? Because all of our training as physicians and scientists says, hey, you're not really supposed to talk about Republicans and Democrats or liberals or conservatives. We have to be politically neutral. But what do you do when the deaths are accelerated from an organized and politically motivated movement? And they're not small numbers. I mean, when you look at the societal causes of death in 2021, 200,000 deaths, that's right up there with, other stuff, gun violence, road traffic accidents, suicide. So I feel that if we're really true public health people and caring physicians, we have to talk about it. Not that we care about their conservative views. That's not our business, but somehow to delink that from the anti-science, from the anti-vaccine stuff, because so many people are losing their lives. Anyway, that's what the new book is about. It's coming out this summer. It's going to make me real popular. It's called The Deadly Rise of Anti-Science, a Scientist's Warning, and it really goes into that. And there's a lot of interesting nuance because the other piece to this are the contrarians. So they've cultivated a group from far-right think tanks, even good universities, that go there as talking heads on Fox News. And what's interesting is the rhetoric they use and you have to be really clever to know how to counter it. So among the things they'll say was, well, who's this Hotez guy talking about this? We're just asking questions, right? Why is this Hotez being so dogmatic? Who's being the real scientist here? And so you've got to be very, very clever in how you counter it. I found this quote from Sir Joseph Rotblat, who was a British and Polish immigrant involved in the Manhattan Project and then was horrified at the consequences of nuclear war. And he started the Pugwash Conference, which ultimately won the Nobel Peace Prize. And he writes, precepts such as science is neutral or science has nothing to do with politics still prevail. They are remnants of the ivory tower mentality, although the ivory tower was finally demolished by the Hiroshima bomb. And so this is the last slide, which to say is now it's spilling over into all vaccines. I mean, we're seeing this play out in the Texas legislature. I mean, some of the really horrible anti-vaccine bills being put out there across Florida and other red states. And now we're starting to see how it's affecting global immunization rates. So the US is exporting this stuff. We're exporting it to Canada with the Freedom Convoy egged on by Fox News. You're now seeing that same US-style anti-vaccine rhetoric and approach, same group of characters involved in far-right groups coming out of Austria, in Germany, in France, and now in low and middle-income countries. And it's hard to document because a lot of it's not in the PubMed searchable literature, so you have to go to local newspapers and things like that. But you're starting to see now in Kenya and Somalia, in Uganda, that same US-style anti-vaccine rhetoric, and it's halting the introduction of malaria vaccines. It's lowering immunization rates. So I had the opportunity to meet with Dr. Tedros at the end of last year to kind of give him a debrief on that. And I think this is going to be a new reality for our vaccine ecosystem. We're not going to bounce back unless we figure out what to do about it. So I'll stop there. And again, thank you, Eric, a good friend, for having me, and happy to spend some time here and take questions. Dr. DuPont.
Peter, wonderful talk. I have two questions, comments and then questions. One is this anti-vaccine movement is hard for me to get a hold of in terms of understanding how to attack it. And I've done two behavior interventions, one in another country, one in this country, trying to decrease infectious diseases through education. And I was able to educate but not change behavior. And nothing happened. And they were both negative. And I decided I was through with that line of research. I'm going to stick with things I could actually have an impact on. And I'm interested if you have, or if your colleagues have any insights how to get a hold of this and how to turn it around. And that's my first question.
It's a great question. I mean, if you asked me that before the pandemic, I would be a little more optimistic, because in the past I've been able to talk with parents and explain to them the risks of measles, and more often than not, if you're willing to invest the time, you could talk them off the ledge and get them to vaccinate. It doesn't happen as much now, in part because their whole political identity is tied to this thing now. So it's become part of the canon. The canon is, the election was stolen, support Russia over Ukraine, and you don't vaccinate. It's become part of people's identity. And that gets, and then if they're, watching this stuff on Joe Rogan and Fox News every night, then they're really down the rabbit hole, and it's hard to bring them back. And so, and there's been some attempts. So one of the things that Vivek Murthy, the Surgeon General, has done is issued an advisory about the social media companies and maybe handle it that way so things don't go as viral like they're. It's not having much of an impact because it doesn't get to those who are generating the content. Or you have a lot of good pro-vaccine groups like Vaccinate Your Family based in Washington, D.C., giving out accurate messages, but it's not reaching those. And so what I've said to the Biden administration is I don't think the health sector knows what to do at this point. I think this has become a political problem. And the stakes are high because, again, this is not just some obscure academic discussion. 200,000 Americans just died who didn't have to. We need to bring in experts from Homeland Security and the Commerce Department, the Justice Department, even State Department, because you have the Russian government using this as a wedge issue. The Russian government is flooding our internet now with bots and trolls, which are both pro-vaccine and anti-vaccine, because their agenda is a bit different. They just want to destabilize democracy. So they see, they cherry pick 4 or 5 big wedge issues, and vaccines are now one of them. So we have to bring in experts from there as well. And so far that there's not been that interest or willingness to do it.
With RNA viruses, they mutate, and this is why we have these variants for coronavirus occurring. Where do you see the future for immunization in this country, considering the mRNA vaccine lack of durability of protection and the mutation rate?
Yeah, no, I think this is what's keeping us all up at night. I have to say, I was surprised at the short-term durability of the mRNA. So, I was the one, I said early on, 2 immunizations aren't going to do it, and I got a lot of credit for that, and I said, but it won't be 1 and done or 2 and done, but it could be 3 and done, because what do we do for our pediatric immunizations, right? We give a series of primary immunizations, you wait 6 months to a year, you get a boost, and then you can get 5 or 10 years of protection. Unfortunately, that didn't happen, and so why the protection against even hospitalizations only up 5 or 6 months, that's troubling. We think maybe there's just something, eventually they'll work it out. I'm guessing there'll be an improvement in the technology, but for now, I've been pushing to get other technologies, like our recombinant protein vaccine. I think as a booster, maybe that would looks like it'll produce more durable protection. The problem is we're not a pharma company. How you get that through the FDA in the U.S., we're having those discussions, but they're not going smoothly.
Well, I guess I want to say one more thing, and that is congratulations to you on all the work you've done internationally and as being a spokesperson for this country throughout the pandemic. You've been a superstar.
Well, thank you, Burden. That's very sweet. And you've been a huge supporter the day I walked onto this Texas Medical Center campus, and I've been so deeply grateful for that, for your collegiality and your friendship and your support and your mentorship. Eric, you were going to say.
So first, thank you for everything you're doing. Two questions. One is science, one's, I guess, anti-science. The science question builds off of Dr. DuPont's comment is, I worry a little bit that even though mRNA vaccines were an enormous scientific achievement on a very short timeline, that we've jumped too quickly on that bandwagon as sort of our only line of vaccine defense. And I wonder if you could promote and think about and talk about a two-pronged approach where we have a sort of a early SWAT attack using mRNA vaccines, but more traditional approaches in the long run, whether that's something we should be approaching.
So let me answer that question first, and it's a very important question. So when this pandemic began, and if you said to me, hey, Dr. Hotez, what's going to be the best technology out there? And you said, okay, ixnay on promoting your own technology. I would have said the VSV vaccine for Ebola, right? Single dose, the Merck vaccine. It was Public Health Canada, then Merck, 90% protection, basically stabilized the whole situation in the DR Congo. I mean, that's going to be the technology. And mRNA, well, we've had our nucleic acid vaccines around for a while. They really haven't panned out. And of course, what happens when you put the spike protein gene into the VSV construct, it didn't replicate well. So that fizzled immediately, and mRNA took off. But I think so the lesson is, I think when you're right, we're running to the mRNA like a little kid's soccer game, right? Where the ball goes off in one corner and everybody goes off in that one direction. And I think it's a mistake. I mean, I don't even know that this was the best test case for mRNA. It turns out pretty much any way you deliver the spike protein, induce neutralizing antibodies and some level of protection. So I don't know that the mRNA technology has really been tested yet. And I think it's a mistake to only focus on mRNA. We've got to keep the others in play because you don't know for the next pathogen that's going to come along.
And then my anti-science question is, we've established the Texas Epidemic Public Health Institute in the school, and one of the pillars is public health communications. And we argue within ourselves a lot about whether we should be constantly chasing misinformation and, meet one for one. And I think we've convinced ourselves that's not the correct strategy. But I wondered if kind of your perspective, because if someone doesn't do it, sort of the misinformation just out-bellows, I guess, the science.
And I think you've got the right idea in the sense that, when I was getting my MD and PhD in New York, the message was, well, you're not supposed to engage the public or talk to journalists. That was seen as a form of self-promotion or grandstanding. And all of those ideas, which are unfortunately still part of the culture, came on board before something called the internet came along. And now the world has changed. So I think as we can think about how we shape graduate education in public health or in medicine or in science, we have to create options for science communication. Because, I had to learn it through trial and error, more error than trial. But there are ways to do that. So I think, it's the right idea, I think. And young people, not everybody wants to do it, but a lot of young people like it. The commitment to public service is at an all-time high. So I think if you offered options as you have in public communications, a lot of people would take advantage because people want to be out there. Young people want to be out there, and it's a minefield, right? I mean, if you ever go to my Twitter site, it can be a scary place at times, and so knowing how to do it and how to avoid making big mistakes, I think that's step one. I think step two is, I don't know anything about the University of Texas system, but generally speaking, academic health centers are not terribly encouraging about having their students and faculty be out there speaking about this stuff, right? I mean, they tend to take a very risk-averse position because they see only the risk to the institution, not the benefits. So at best, what you'll get is, hey, you're an academic, you're free to speak out on whatever you want, but don't screw this up and don't get the institution in trouble. And that has a very chilling effect, right? You've got the sort of Damocles over your head. And it's even more complicated in a place for a public university in Texas that's dependent on money from the state legislature over fear of retribution. So you have that as well. So all of that needs to be explained. And I think, that's why it is so important to do it.
Hi. Great talk.
Thank you.
I had a question. You're working with a lot of these governments in low to middle income countries in proposing these new vaccination strategies for neglected tropical diseases. And I was wondering, you're working a lot with government officials, and is there the same level of politicization, like in this, blue versus red about how they would receive these types of vaccinations? Because I wonder if there's obviously some.
So I'm
demographic
working
change.
mostly with the leaderships of the vaccine producers and allow them to do the government interactions because they know where the minefields are, they know the subtlety. But there's no question now that the anti-vaccine movement is global, and it's changed. So in the past, many of you probably know the great work of Heidi Larson, who's a medical anthropologist at University of London, and she's been writing about vaccine confidence for as long as I have, but more from the European side and the global side, and always talking about how each country has its own, unique little shop of horrors when it comes to its anti-vaccine movement. And in the past, pre-pandemic, Heidi and I would meet at meetings, and we never quite understood each other because what I was seeing in the U.S. was so different from the way things were unfolding in France or the UK. Now we're starting to come to some convergence because that same US style of health freedom, medical freedom, very aggressive, is now contaminating countries all over the world. And now we're starting to kind of understand that a little better. So you still have the unique aspects, right? You have in Pakistan and Afghanistan the assassination of polio workers, right? But now folded on top of that is that kind of US style anti-vaccine rhetoric, and that really concerns me.
So I have a question from the folks online. Can you give tips on how we can practically navigate conversations about the relationship between anti-science and politics in the professional setting in a red state?
Yeah. I mean, that is the question, and I'll start answering it. I mean, as we say in Texas, do you want the short answer or the long answer? And the short answer is I don't know. The long answer is it can be extremely challenging, and again, the way I've done it is to say the people who've refused vaccines are victims, and it's not to blame the victim, that they didn't do anything wrong necessarily, except make a poor choice in the face of a massive disinformation campaign, and so that has been somewhat useful. Unfortunately, what you're seeing now is, as I've called out, the House Freedom Caucus and others, rather than that being pause for self-reflection, they're doubling down. And so what you're seeing now is a whitewash of everything that's happened over the last 2-3 years. So now the public statements are, wait a minute, it was the COVID vaccines that killed people, not COVID, right? That's what they're saying. Or, by the way, the scientists created that virus in the first place, and all the gain-of-function lab leak stuff. So basically, it's portraying scientists and physician scientists as enemies of the state. And that's what you're seeing play out now in the House hearings with the COVID subcommittee. And it's going to get worse before it gets better, unfortunately.
Thank you very much for your lecture. I was wondering if you could say something about vaccines that are delivered through inhalation, like there's an influenza one now, and they may have a better response with IgA, and also will they possibly be more acceptable to certain subgroups?
It may be. So there's a lot of interest in mucosal delivery mechanisms, meaning intranasal, oral, sublingual. We're working with a group at MD Anderson on those approaches, as are others, and they offer promise. It's been hard to get that same level of systemic immunity, because ideally you want both. One of the things that I say is, actually, the mRNA vaccines, as well as others, gave actually pretty good levels of mucosal immunity. I think the levels of virus neutralizing antibody were so high that we were getting some levels of IgG into the nasal mucosa to stop virus shedding, which was how that was working. So you didn't necessarily need the intranasal approach, but as the Omicron variants took shape and you couldn't keep up with them, that became problematic. So it's not like there's no mucosal immunity from these vaccines that are given parenterally. But I think we again, with the innovation, it's always desirable to keep pushing that and to see how they do. I don't know. I mean, right now, the anti-vaccine groups have on their radar screen an introduction of any new vaccine. And so I was at the World Vaccine Congress in Washington. I just flew back last night and said, there's all this excitement about new vaccine technologies, but introducing new vaccines now seems to be the battleground of the anti-vaccine groups, and that's going to get harder and harder. I don't think people understand how problematic that's going to be. As I sometimes say, the world is littered with good vaccines that were voted off the island because of public perception, right? So we had a good Lyme disease vaccine made by GSK, but because of public perception, it got derailed. Now Pfizer's trying a new generation one, but the old one actually worked pretty well. Same with the dengue vaccine, from Dengvaxia from Sanofi. It had a lot of good, but the public perception was there, and it killed it. And I think that's what's going to happen now with future new technologies, because it's so revved up. Yes?
So when I've been speaking with people who are anti-vax, a lot of the rhetoric they've given me has actually been pulled from the news, from credible sources, but they've broken it down so far into layman's terms, so far into black and white qualities, that it isn't completely true anymore. And I'm wondering, are we dumbing down science too much to the point where we're not actually being factual anymore?
Yeah, I think that's absolutely true. And so one of the things that, when I started doing this, I was told that you've got to talk to the American people like they're in the 4th grade or the 6th grade. And I actually found that's not true. And I haven't done that. So if you listen to my broadcast, I go to a fair bit of complexity. I try not to avoid using jargon, but I go into a fair bit of complexity because I believe that the American people, if their lives depend on lives of their loved ones, want to hear the details so they can make more informed decisions. And I think that's been part of the problem with the U.S. federal agencies, CDC, FDA, and NIH, is they still cling to that old style way of communication, and it rings hollow. So they would just kind of give these summary statements without backing up their assumptions, and it becomes easier to debunk. So I absolutely do think that, and these traditional ways of 4th grade, 6th grade level communication, I think it doesn't work. People are becoming a lot more sophisticated. I mean, and then you get the quarter of the country that's 3 million Fox viewers every night, and those are really hard to reach. So I think the other reason that the CDC still clings to that old way of communication is they want to reach everybody with one message. And it doesn't work, because you got one group that's willing to tolerate a lot of complexity and another group that's not listening at all. And so when they try to amortize and they try to use one message, it comes out sounding like baby talk. And no one's happy with that. And I think that's the mistake that they've been making. Yes?
As a follow-up, so you would suggest when discussing these things, we do discuss them at a higher level, maybe not the way we would with our scientific peers, but at a higher level, and just anticipate it would take more time to make that explanation rather than give generalization.
If you can get it. I mean, it depends on the news cycle and what else they've got going. Sometimes you don't get the time you'd like. But then when I would try to follow it up on Twitter, and I would say, okay, I didn't get the time to give you the backstory here, but here's the backstory, and people generally like that. So there was an education process. And by the way, I spent a lot of time talking with journalists. I would spend, 20, 30 minutes at a time with a journal, because most of the journalists writing about COVID didn't have a science or background. They were pulled and they had to write about it. So I'd spend half an hour with, the New York Times journalists or the Wall Street Journal, and they appreciated it. And I think you don't get, and sometimes you wouldn't get any credit for it, right? You wouldn't even get any attribution to you, but it was okay. Over time, you became a trusted source for the journalists, and in time, they learned a lot. They had kind of a crash course in virology and epidemiology.
Thank you so much.
Sure.
Sorry. So I had a couple of points. So I think with that, and also going on with what Dr. Boerwinkle was saying, is that, and you've been talking about this, is that it's taking public health from health education to really going the way marketing firms work. And there's, things that can be sold to people that they don't need. So it's along the same level of, getting sentiments and emotions and all those things involved. And then people also have a sophistication in their own field. I mean, these are adults, even if they have high school education, that are making very complex decisions about a lot of things. So they're able to, if there's parallels to be made in the context they understand, that can always
Well, I think you're right. I mean, in terms of appealing to core human values, so there's this one, for the book, I started reading some of the stuff by this health communications person at Cornell, Valerie Reyna, who talks about appealing to core human values. And I think that's extremely important as well. So it's not only providing the information, there is that kind of marketing approach. Absolutely.
I actually had a second question as well. I was going to ask you about what you were saying, like when you're working in an industry context, we're also talking about return on investment and things in a certain way in the work that you do. And you were talking about your lab being like a mix of what a high level sophisticated lab would be, but also a public health institution. So I was curious about, like in the work that you guys have done, I'm a health economics student. So what would you say like that framework looks like in the public health realm in terms of bringing the same level of return on investment, but from a society, public health perspective, like labor productivity loss, even if it's that person in Alabama who's going to pass away or not being able to be the same level,
Well, this isn't quite the answer to your question, but I think it's become pretty obvious to everyone now that the public health impact of COVID was only the first part, because there was an equally devastating impact on the economy, on social infrastructure, and global security. And so I think it's going to be really important that we have that dialogue with our colleagues in business schools, in political science, in economics, in law, because we now realize that pandemics are much more than the public health impact, and how we have that discussion is going to be really important. So a couple of things have happened now at both Oxford and the University of Liverpool, with the Liverpool School of Tropical Medicine. They've created these very innovative pandemic sciences institutes that attempt to do that, bring in people from all areas. And I think that would be worth looking at as well. Because, across Houston, right, or our educational institutions, there's a lot of heft in all of those areas, but we tend not to talk to them as much as we should, I think.
So, Dr. Hotez, we could keep you here all day. How do you feel about that?
Sure, why not?
So we want to be very respectful of your time. I don't know if you want to answer a few more questions, or if you want to answer some
we
of
can
these
let
in
people
email.
go, and if they want to come up to me and talk, I'm happy to talk until Douglas tells me I have to
There's some of the
leave.
questions that are from the webinar that are online.
Oh, okay.
So I don't know if you want to maybe address them later.
Why don't we pick two quick questions?
Two quick, okay. So has COVID and the COVID vaccine race pushed the timeline of other vaccine development programs back? And if yes, how can this be prevented in the event of a
Well,
future
it works both ways.
vaccines?
I think one, it's prioritized COVID over other things, and so that may have slowed down some R&D programs. On the other hand, I think we saw a lot of consolidation of clinical trials and made people realize that we can move a lot faster than before. So it might have some accelerating effects as well.
All right, we'll finish on this one. I did not realize this, but apparently Robert F. Kennedy is a prominent anti-vaccine. I knew he was an anti-vaccine activist, but I didn't know that he had just declared his campaign for president for the Democratic presidential nomination. So are you incorrect that anti-vaccine movement is exclusively of the right?
I think, whether he's running as a Democrat or Republican is irrelevant, really. But I do think it's a sign that how powerful the anti-vaccine forces have become, and the fact that he feels emboldened now to run for president of the United States on an anti-science platform. That should give us, even though I doubt the candidacy will go very far, it's still going to give him a lot of attention and a big voice to all of this.
All right, so from all of us here, thank you once again for coming to speak with us today.
Thank you again.
Just to commemorate the 31st
thank you very much.
annual Steele Lecture. Thank you.
Thank you so
Thank you
much.
very much.
Thank you.